Well, good morning and welcome from Toronto, Canada. My name is Anna Sangster, Director of Policy and Innovation at the International Federation on Aging. In recognition of Shingles Awareness Week, it is my absolute pleasure to be moderating the Influencing Action on Shingles Vaccination Policy webinar, which aims to increase our collective understanding about shingles infection, current vaccination policy in the EU, and the crucial role that immunization plays in safeguarding the health of older adults. It is a privilege this morning to be joined by two speakers who will be sharing their expertise and experience with us. Before I hand things over to our first speaker, however, I wanted to briefly review some general housekeeping. First, the webinar recording and slides will be made available to all registrants post-webinar. Second, you are encouraged to use the Q&A function to submit any questions you may have regarding today's presentations. Questions are welcome throughout the session. However, all questions will be addressed during the dedicated Q&A period after all presentations have been completed. With that said, it is now my pleasure to introduce our first speaker of the day, Dr. Jean-Paul Stahl. Dr. Stahl received his MD from the Faculty of Medicine, Grenoble, and has maintained several teaching positions and research roles in the field of microbiology, epidemiology, virology, and infectious diseases. In these roles, he has become the head of infectious disease department at the University Hospital of Grenoble. He is currently the chair of the infectious disease section in the European Union of Medical Specialists, a member of the French Infectious Disease Society, and a member of the European Society for Clinical Microbiology and Infectious Diseases. In addition to these roles, he has previously been involved with the ANSM, the French Drug Agency, and the French Ministry of Health in various positions relating to vaccine policy, vaccination communications, and management of infectious diseases. Dr. Stahl, thank you so much for joining us today. It's an absolute pleasure to have someone of your esteem with us. The floor is yours.
Okay, thank you for this nice presentation. My mission is to give you some update about shingles. I mean, probably the most. I try to give you the most recent knowledge about this disease, this infection. So, may I have the first line, please? Okay, then here is our friend, the virus. Not really a friend, you'll know, you'll see it. Next, this virus is included in a large family that is the human herpes viridae. In this family, there are herpes simplex viruses, type 1 or type 2. It is the most frequent presentation of this virus. And the most severe, we'll see it later, and responsible for the most severe presentation, that is encephalitis. Herpes virus varicella, responsible for chickenpox and shingle. That is our virus today. Cytomegalovirus, extremely frequent in the population, but really important for in case of pregnancy first. That is a frequent condition, as you know, and as well as very severe in case of immunosuppression. Epstein-Barr virus is responsible for EBV infection, that is mononucleosis. And there are other viruses, 6, 7, and 8. 8 is responsible for the Kaposi's syndrome, that is an opportunistic infection in HIV patients. So, VZV is our virus for today, and we'll see more. Next, please. That's the most usual presentation of varicella, and it illustrates the herpes viridae cycle. That is the primary infection, and then next, then the virus sleeps for a long time, and sometimes never wakes up, but sometimes it wakes up. And we know currently that roughly 5% of trigeminal lymph nodes neurons are carrying latent viruses able to wake up. Next, and then there is the recurrence on the left hand side, the herpes, Everybody knows that. And right inside the zoster, that is the resurgence of varicella. It is impossible to present with zoster if you did not had varicella before. So there are some risk factors for resurgence, of course. Not all is known, but what we know, it could be following a local stress, like a blow, the sun, and a lot of other local stress. But general condition is also involved in this case. That's the general stress, but it is very difficult to assess the responsibility of this stress in the resurgence because, well, you have stress all the time and for any reason. And so it is very difficult to have a clear relationship between the stress and the disease. But for sure, immunodepression of all causes is responsible for resurgence, and it includes age. The global epidemiology of zoster has to be known. Look at this, and it illustrates the importance of the age. The risk for presenting with zoster during one's life in general population is from 10 to 30%, according to various studies. But look at the incidence. The incidence is 3 out of 1,000 person year before 30 years old. You have to be aware that in fact it is rare. But if you are more than 45 years of age, there is about 60% of cases that are occurring in this period. And look, after 60 years, the incidence is 8 out of 1,000 person year, and it is 10 out of 1,000 after 80 years or 80 years of age. That means that it is way more in this age than in young people. And it explains what happens with the vaccination. We'll see it. I am really sorry to this slide that is in French, but I will explain. That is we could say the weakening of the immunity when you are aging. At the organ function is on the left, and the basis is the age. And the curve 1 is the normal aging. Year by year, you are losing function of any organ. That's a pity, but that's reality. If you present with the chronic disease, that is the curve number 2, and then you go till the threshold. That is the line that is the threshold for insufficiency or failure. And then you see that you go very rapidly with the line 2. In case of chronic disease, you go rapidly just below this threshold of failure. And in case of acute disease during any period, then there is a higher risk to go below this threshold. That is a general concept of the influence of age on the organ function. So about the clinical presentation of zoster or shingles, it is really simple. It is a cutaneous rash that frequently preceded by metameric pain. There is no fever, and most frequently it occurs in the thoracic area, but all localizations are possible everywhere: abdomen, eyes, ear, face, pharynx, sciatic nerve area, and so and so. Less frequently, they are encephalitis, but look at the arrow. VZV is the second identified cause of acute encephalitis in France. The second one, after HSV, VZV is the second cause. That is, it is not, obviously, it is not frequent if you just look at the numbers. But if you look at the percentage, it is extremely important. Fortunately, there is a treatment. The localization in eyes is extremely important due to complications and the importance of it. This study reported 134 cases in a large population. So that means a global incidence of 30 out of 100,000, and the incidence was 104 in 100,000 people after 65 years old. That means it is 5 times more frequent than in the global population. That illustrates clearly the importance of the age in the risk factor. And 31% of these patients presenting with this localization of zoster suffered from post-zoster neuralgia. That is an extremely important pain after the zoster itself. And then they identified risk factors for neuralgia as age, keratitis, conjunctivitis, or uveitis. And so the complication of the zoster are first spreading of the rash. That is extremely frequent in case of immunosuppression. Super infection of vesicles, most frequently streptococcus or staphylococcus. Zoster is considered as a marker for higher death rate due to the infection itself and due to the fact that it is a marker for comorbidities and important comorbidities. And of course, the most impacting for the next month and sometimes years is neuralgia. So the frequency of this neuralgia, again, two studies. You see what happens at 3 and 6 months after zoster. It was 32% at 3 months and roughly 18% at 6 months. Another study called Arizona, and no relationship with the US state. It is Zona is the French name for zoster. So they look at the persisting pain 3, 6, 9, and 12 months after zoster itself. So it goes from 11% to 6%. So 6% after 12 months. And this pain is very, very, very important. It could be a real handicap for patients. And the risk factors are age, again, prodromal symptoms before the rash, severity of the rash, importance of pain, ophthalmological injury, and maybe, not sure, maybe female gender, nobody knows why, psychological stress, but everybody has anytime psychological stress, and comorbidities. There are treatments. It is acyclovir, IV, valacyclovir, oral route, and foscarnet, IV in case of resistance of the virus to acyclovir, but it is a very, very rare condition. There is a limitation to the efficacy of this treatment. That is the time for initiating it after the onset of the disease, and the maximum is 72 hours after the initial symptoms. If you prescribe it later, it is absolutely useless. When there is pain and neuralgia, then you have to use pain relievers in a lot of cases. In the acute phase, they are, I would say, standard pain relievers, level 2 analgesics that are the most frequently effective. But in case of neuralgia, you have to use really important pain relievers, and with some very significant side events, amitriptyline, carbamazepine, gabapentin, or pregabalin. The prevention. What about the prevention with drugs? The prophylactic acyclovir is recommended by some experts in case of scheduled immunodepression before the immunosuppression, but it is still under investigation. It is not really clearly demonstrated. This prevention could be finally copy-pasted from the prevention of CMV using valganciclovir in case of immunosuppression. And there are vaccines. There are currently 2 vaccines. I'm speaking about France. Zostavax is currently validated for patients over 50 years of age, but reimbursed only from 65 to 74 years of age, because before 65, it was said that the frequency of zoster was not important enough for global reimbursement for all. After 74 years of age, there is no clear demonstration of efficacy due to the normal immunosuppression with the age. And there is another vaccine that is marketed in other countries, and I think in the US, no worries, but not in France so far. Shinglesrix. So the Zostavax efficacy is demonstrated. It is an attenuated live vaccine. There is a reduction of the zoster incidence by 65%. It is not a tremendously efficient vaccine, but it works. In this age group of 60 to 69, but only roughly 38% in the group aged over 70. That is an explanation for the absence of reimbursement after 74, because it is considered that the efficacy is not high enough. The risk for presenting neuralgia was roughly 9% in the vaccinated group versus 12 in the placebo group, and still in the age group 60 to 69. The risk was 10% in the group over 70 years old, and roughly 18 in the placebo group. So there is an efficacy that's clear in preventing zoster as well as preventing neuralgia, but there is still an unmet need. And then the Shinglesrix was approved by EMA in 2018 for patients over 60 years old, just like Zostavax. It is available in Germany, but not yet in France. It is a vaccine slightly different. It is not an attenuated vaccine, but a vaccine using recombinant protein. The efficacy on neuralgia is very important, according to the trials, 90 to 100%. According age groups, And the efficacy on zoster itself is 91 to 97%. That is clearly better than those tabacs. So I will answer all your questions, and I, of course, remain yours for this. Thank you.
Thank you so much, Dr. Stahl. I know I already have a number of questions percolating, but before we get to dive into questions, we have one more exciting presentation. It is now my pleasure to introduce my colleague, Ms. Emma Schmidt, who is a project officer at the International Federation on Aging and lead for the Influencing Action on Shingles Vaccination Policy project, of which she'll be sharing some key findings today. Emma has a Master's of Business Administration and is currently pursuing her Master's of Public Health with a focus on health equity and the social determinants of health. Emma, thanks so much for joining us today. The floor is yours.
Hi, everyone. Thank you. Thank you for attending our webinar on influencing action on shingles vaccine policy. And thank you, Anna, for that introduction. I am very pleased to be sharing the findings of the research conducted by the IFA on shingles vaccine policy across the European Union. Current data illustrates that 1 in 3 adults will experience shingles within their lifetime, and most of these individuals are over the age of 50. Despite the proven efficacy of the shingles vaccine in preventing and reducing the severity of disease, its value has been hindered by a lack of awareness and integration into robust immunization policies. The study, Influencing Action on Shingles Vaccination Policy, aims to assess the status of shingles vaccine policy in 14 countries across Europe, highlighting gaps and informing a call to action on the importance of improving awareness of vaccine-preventable diseases such as shingles and the need to increase the uptake rates of adult vaccination as a key preventative action towards maintaining the health and well-being of older adults. Population aging is progressing at a rapid pace worldwide and poses challenges for countries' economies, with the health of older populations being of considerable concern. There are currently more than 1 billion people over the age of 60, representing 14% of the global population. By 2050, this population will have more than doubled to 2.1 billion. With increasing age comes changes to the functional ability and an increasing vulnerability to chronic comorbid conditions. To foster well-being in older age and to decrease health system costs, it's imperative to establish comprehensive public health responses that focus on developing and maintaining intrinsic capacity and functional ability across the life course. Vaccinations are, of course, one of the most effective public health interventions of our time and are a key to preventing disease, maintaining function, and fostering healthy aging. Despite intergovernmental agendas such as the World Health Organization Immunization Agenda 2030 and the UN Decade of Healthy Aging, where a life course approach to immunization is central, the uptake rates of routine adult immunization against shingles remain suboptimal. So why are we interested in looking at shingles specifically? Older adults are at the greatest burden and risk of shingles, with the highest burden being in those over the age of 50. Approximately 24 to 30% of individuals will develop shingles over their lifetime, and this risk increases with age. A diverse array of factors contribute to the increased susceptibility of older adults to shingles, which Dr. Stahl touched on earlier, including the presence of comorbid conditions and a decreasing immune response. Exemplifying this point, a number of studies have described the occurrence of shingles following a COVID-19 diagnosis or related hospitalization. In the midst of a pandemic in which older adults are already at an increased risk, prevention must be prioritized. Beyond the characteristic rash, shingles can also result in severe complications such as neuropathic pain, vision complications, and long-term hospitalization. Despite the known benefits of shingles vaccination, comprehensive national immunization programs are sparse, resulting in diminished awareness, access, and uptake of the shingles vaccine. Similarly, reimbursement of the shingles vaccine, which can be full or partial, varies widely across Europe. Even in countries where shingles vaccination is recommended, it is not always fully funded, which poses a significant barrier to receiving vaccination due to the high out-of-pocket costs, creating inequity to access of the vaccine. The Influencing Action on Shingles Vaccination Policy is a multi-phase initiative that gathered information on the current status of shingles vaccine policies across 14 countries in Europe. For each of the 14 countries studied, information was obtained, including whether there is an established national immunization technical advisory group, as well as the NITAG's criteria or processes for recommending the addition of a vaccine to the National Immunization Plan, as well as the shingles vaccine recommendations across age groups, if there's funding provided, what the vaccine coverage rates are, and the processes for monitoring vaccine coverage. To further understand the context of the environmental scans, a series of interviews were conducted with experts in the field of infectious disease and immunology. These interviews aim to explore the barriers to adult vaccination in general, as well as those specific to the shingles vaccine, and discuss what action should be taken to improve the uptake of shingles vaccination and support its inclusion within national immunization programs. So here's a brief overview of the findings that this project found. Ultimately, through the analysis of the policy landscape across nations, this study will help to improve the rates of routine immunization among those most vulnerable and those with declining capacity. We looked broadly at policy related to if there are federal recommendations for older adults to receive shingles vaccine, if shingles is included within the National Immunization Plan, and if the shingles vaccine was funded. Findings were consistent throughout both the environmental scans and the expert interviews, which highlighted a lack of consistent policies around adult shingles immunization across Europe, including a lack of comprehensive government funding for the vaccine. This overview kind of highlights the findings that we'll be diving into a little bit more throughout the presentation. Notably, 43% of countries did not have a federal recommendation for shingles for older adults. 50% of countries did not include shingles within the national immunization schedule, and 71% of countries did not provide comprehensive funding to all older adults to cover the cost of receiving a shingles vaccine. All countries studied had a National Immunization Technical Advisory Group, which provided the Ministries of Health with evidence-based vaccine-related recommendations. In Belgium and the Netherlands, the shingles vaccine is recommended by respective NITAGs, but it is not included within the National Immunization Program and is not publicly funded for adults 50 years and older. In the Netherlands, public funding is only available for adults who are immunocompromised, and in countries such as Austria and Spain, the vaccine is recommended, but again, is not publicly funded or is only partially funded for immunocompromised individuals in some regions. In Germany, Greece, Italy, France, and Switzerland, the vaccine is recommended and included, and in most of these countries, it is fully funded. However, there's only a partial subsidy in France. And there were no recommendations for the shingles vaccine in Finland, Sweden, Denmark, Norway, and Portugal. The type of vaccine recommended for use against shingles also differed across countries. The non-live recombinant subunit vaccine was used in Austria, Belgium, Denmark, Finland, Germany, the Netherlands, and Sweden, while in France and Greece, the primary vaccine is the live attenuated vaccine. And then in Italy, Norway, Spain, and Switzerland, there was no specific recommendation regarding which vaccine can be administered. Further, to understand access to vaccination, the various pathways to obtain vaccines were examined in each country. In most of the countries, the vaccine is exclusively administered by general practitioners and nurses. However, vaccines can also be administered in regional and local counseling centers, primary care centers, and vaccination clinics, as seen in Austria, Finland, and Sweden. And they may be administered by community pharmacists in Greece, Italy, and France. Current pathways to vaccination were not identified by any experts as potential barriers to receiving the shingles vaccine at this time. However, previous studies have shown that direct recommendations from healthcare providers greatly increase uptake rates, which provides an important opportunity to target healthcare professionals with health messaging campaigns to ensure they are communicating the risks associated with shingles and recommending vaccination to older adults where appropriate. Across the country studied, information on shingles vaccine coverage rates was not publicly available. Without this information, there is no knowledge base from which the burden of disease and costs associated can be properly understood in these countries. Establishing systems to monitor shingles vaccine coverage rates is critical to helping countries prioritize and tailor vaccination strategies to address shingles immunization gaps. Throughout the structured interviews, experts shared their perspectives on the barriers to adult vaccination in general and those specific to shingles, to then inform actions to be taken to improve the uptake of shingles vaccination. There were three main barriers that these interviews identified. This included a lack of information from both the general public and from policymakers on the severity of shingles and the value of vaccination throughout the life course, as well as a lack of funding for individuals who are seeking vaccination in countries where it's not currently comprehensively funded, and the impact of COVID-19 on creating an overburdened healthcare system and making it difficult to allocate funding towards other infectious diseases, as COVID was prioritized by governments over the past few years. The general lack of knowledge identified by experts across the countries on the importance of adult vaccination and the shingles vaccine is a large barrier to overcome. There was a clear call for larger health messaging campaigns around shingles and the role that vaccination plays in preventing the disease. Examples of health messaging could be found in many of the countries studied, such as the one included on this slide from a regional health authority in Italy. However, most experts concluded that the health messaging is currently not meeting the need or not addressing the gaps that it should be. All experts noted the latest development in the shingles vaccine, and many believe that policymakers are not yet fully aware of the benefits of vaccination against shingles and the role that this vaccine could play within national immunization plans. While adult vaccination was identified by experts in each country as being important, childhood immunization remains more comprehensively funded and included within national immunization programs. Misconceptions from the public around the severity of shingles infection was also highlighted by many interviewees. There is also a reported lack of knowledge and understanding from policymakers around the costs and benefits of the shingles vaccine to health and social care systems, as well as the workforce. Previous studies have estimated that the total cost for governments to immunize a healthy individual in Europe with all NITAG recommended vaccines is 16 to 27 times lower than the cost of associated hospitalizations. Therefore, the cost to fund vaccine campaigns is a low-level investment with potential savings in reduced treatment costs and increased productivity. And this ties into what was identified as the greatest single barrier to shingles vaccination in Europe, according to the experts interviewed, which is the cost of vaccination. Older adults who are at the greatest risk of shingles infection are often living on fixed incomes. The cost, therefore, of vaccine is prohibited if there's not at least a partial subsidy available. One expert also shared their belief that the cost of vaccination may be one reason why physicians are hesitant to recommend the vaccine to patients that they are seeing. Sustained investment in a population-wide immunization program is an effective way to improve vaccine access and uptake rates. Yet government funding for shingles vaccine was inconsistent across all countries studied and represents a substantial barrier, creating inequity in access to the shingles vaccine. As previously discussed, there are expected cost savings for governments when prevention is funded. With this knowledge and the understanding that having to pay out of pocket for vaccines is a large barrier, working to promote government funding remains a crucial step in promoting access and uptake of adult immunization for shingles. And lastly, COVID-19 was seen as both a mechanism to support the conversation around adult immunization, as well as a deterrent for current policy change due to governments prioritizing COVID-19 over other infectious diseases. One expert highlighted the role that COVID-19 has had in promoting more research grants and general interest from both governments and the public around vaccine preventable diseases. They concluded that COVID-19 raised awareness of the importance of vaccine. However, it also spurred efforts of some anti-vaccination movements, which remain a vocal minority in many of the countries studied. COVID-19 provided evidence of the safety and efficacy of adult vaccination and reminded adults to check their vaccine status for other vaccine preventable diseases. The pandemic had also demonstrated the ability of governments to develop, implement, and monitor immunization policies for the health of all citizens, especially for those most at risk of serious complications and death. Despite the ways in which COVID-19 has raised the issue of adult vaccination, it has also taken up much of the efforts, resources, and priorities of governments and policymakers. Most of those interviewed reported that COVID-19 appears to have slowed the progress to include other vaccines in national immunization schedules, as policymakers and healthcare professionals have been occupied with pandemic response initiatives. One expert suggested that COVID-19 has also resulted in adults falling behind on their routine immunizations due to widespread closures of healthcare centers during the pandemic. As a result, this may contribute to adults not seeking additional or elective vaccines, such as the shingles vaccine. Leveraging and building upon the dialogues related to adult vaccination that were initiated during the COVID-19 pandemic represent a crucial opportunity for researchers and advocates. However, many experts noted that interest in this topic is waning as governments and the public experience greater levels of pandemic fatigue. The pandemic has resulted in a unique opportunity to capitalize on current interest from both policymakers and the public to expand national immunization programs to include shingles vaccination and to better protect high-risk demographics such as older adults. It is therefore necessary to take immediate action to build upon the opportunities created and the increased awareness of adult vaccination by COVID-19. Remaining vigilant and continuing to promote the conversation of adult vaccination post-pandemic is necessary to prevent lost progress. Additionally, civil society was viewed as a crucial player in advocating for older adults and working with academia and governments to promote the inclusion of shingles within national immunization programs. It was identified in the interviews that for many countries, civil society has established a lasting relationship with government that can be used to influence policy change and raise awareness among government officials on the importance of vaccination. Experts highlighted the importance of interdisciplinary collaboration, which can foster greater trust in health messaging and bridge the identified gaps in knowledge. Again, this project found that only 50% of countries studied included shingles within the national immunization program, and only 28% provided comprehensive funding. Therefore, the International Federation on Aging is calling on policymakers, healthcare authorities, and healthcare professionals to act on the following. There's an urgent need to advocate for and prioritize the inclusion of shingles vaccination within national immunization programs, including the provision of funding to reduce barriers to access. There's a need to promote new surveillance methods that collect robust, age-disaggregated data on rates of shingles vaccination. Mobilizing this data to better understand the cost and benefits of large-scale vaccine campaigns and setting clear coverage targets is also necessary. There's a need to develop and disseminate information that can help to increase the awareness of shingles, including the severity of shingles infection and the increased risk that older adults have to the disease. And lastly, there's a need to improve and expand pathways to vaccination through non-traditional vaccinators, such as pharmacists and nurses. The IFA is launching this call to action as a part of Shingles Awareness Week, and we encourage everyone to view the full report and call to action to determine the role your organization could play in improving vaccination rates within your country. Some key messages before we end here. Despite consistent NITAG recommendations for the use of the shingles vaccine, many countries have not integrated the shingles vaccination within national immunization plans, and even fewer offer funding for the vaccine. There's a pressing need to not only prioritize the implementation of NITAG recommendations, but also associated funding of these recommendations. Without this action, it is expected that shingles vaccine awareness and uptake will remain suboptimal. In addition to the lack of funding, there remains a disconnect between the knowledge created by researchers and the understanding of the public and policymakers around shingles vaccination, disease burden, and the risks associated. Developing comprehensive vaccination campaigns and related knowledge translation efforts can work to bridge the gap and has highlighted the pivotal role that civil society plays towards improving shingles vaccine rates. Given the substantial socioeconomic burden of shingles among older adults and its grave impact on their overall well-being, there's an urgent need to prioritize shingles vaccination policy to ensure healthy aging for current and future generations of older people. Lastly, I'd just like to take this time to acknowledge the experts that provided key insights into this body of work and thank GSK for funding this research through an unrestricted educational grant.
Fantastic. Thanks so much, Emma. It's such an exciting study and so many really, really interesting findings. I'm very excited to get into our question and answer here and already have some questions rolling in. I think our first question was about COVID, but I think you covered that quite comprehensively, Emma, in terms of the barriers and opportunities. But I do want to give Dr. Stahl the opportunity to kind of comment on that from his perspective and kind of give us an idea, Dr. Stahl, of what you've seen through COVID. I think we've seen kind of this benefits and challenges. We've seen kind of, for the first time, probably more conversation about adult vaccination than we've had in the past, but we've also seen kind of a potential regression in some of the uptake of other vaccines outside of kind of COVID-19. So would welcome your thoughts on that.
Well, there are some various answers. The first one could be related. The first one is related to the frequency of herpes infections during the COVID crisis, and it decreased dramatically. We don't know exactly why, but probably the barrier measures that were implemented for the prevention of COVID transmission could have some responsibility in this. Not fully, but probably a part. Just for example, during the COVID crisis, we didn't see any more HSV encephalitis. That is very surprising because it is not a direct transmission. It is a resurgence. The encephalitis is not a primary infection. It is a resurgence of the endogenous carriage of HSV. And during the COVID crisis, no more encephalitis, HSV. So it is surprising, and we still don't know why. But there was an impact. That's absolutely obvious, and it is due to a lower transmission rate. That's the first point. The second point is the COVID crisis responsible for a better awareness about vaccines, about prevention? Well, it is up to us to convert this because it was the COVID was a clear demonstration that the vaccine is useful. It saved hundreds and hundreds or thousands and thousands of lives in the world. So it is a clear demonstration that the vaccine is useful. But the translation
Thanks very much, Dr. Stahl. A question here from Shmuel, who's a frequent flyer of ours, and happy to have him here today. A little bit about what role governments and authorities play in ensuring kind of equal access for marginalized groups and low socioeconomic groups to vaccines, and kind of, that question of vaccine equity, kind of what role do governments and authorities play in addressing that? So perhaps I'll come to Dr. Stahl first, and then Emma, if you'd like to jump in, you're welcome to as well. Dr. Stahl?
Oh yeah, it was no, the government responsibility. Well, they have to they have to provide a better communication. I am speaking about France because I don't know what happens in the other countries, but about France, they are really not good at all about communication in this field. They are more than bad. So they have to do it, and they recently gave a very bad signal about the COVID-19 vaccination, and they are on the way not to recommend it anymore in the general population. Wow. That's a very, very bad signal. And I don't exactly know why, because I am not the health minister, as you know, but maybe it is a matter of money, because it costs a lot. But I am pessimistic. I am pessimistic about that. The other point, the responsibility or the other impact the government can have is to fund the vaccination. That's clear. That's absolutely important, because modern vaccines are expensive. It is not the €5 for polio. It is much more now. The other positive point is that yesterday the president said that the vaccination against HPV will be recommended in a specific plan. So on the other part, one side they don't recommend any more COVID, and on the other side they have a plan for HPV. So pessimistic one side, optimistic the other side.
Sure.
But that's the way the government, and it is very important. I mean, in France, it is very important. It is very important, and the perverse impact is that when you don't like the government, you don't like the vaccines, even if there is no relationship between both fields. But it is so clear that the government is important in this field.
Thanks, Dr. Stahl. Somewhat related, Emma, when identifying barriers to shingles vaccine, it was mentioned that lack of knowledge was a significant barrier. In the research and interviews you conducted, was there any mention of the role of healthcare professionals in kind of helping to increase awareness, or what their role would be in kind of the lack of shingles awareness among older adults?
Yeah, definitely. Thank you for that question. So, the role of healthcare professionals is kind of twofold. There's the direct recommendations that they can make to individuals, particularly to older individuals, encouraging them to receive their shingles vaccination, or providing knowledge on the risks and the severity of shingles infection, which definitely is a crucial role that needs to be addressed. And some of the experts identified shared that they felt healthcare providers may not be um, providing those recommendations as frequently as they could be, which is largely due to just, time constraints that a lot of healthcare providers have when they're meeting with patients, as well as, the impact of COVID on just creating a burdened healthcare system. Um, as well as healthcare providers can definitely work with governments, as Dr. Stahl was mentioning earlier, and act as patient advocates, which remains a crucial role that needs to be filled. And I think that plays a lot into the importance of interdisciplinary collaboration between civil society, healthcare professionals, the government, researchers. There's a lot of key players in this conversation, and to have the largest impact on addressing these barriers to knowledge, there needs to be discussions amongst those groups and like large spread collaboration.
Thanks very much, Emma. Dr. Stahl.
Yeah, I just like to comment about the importance of a healthcare professional. I am in a group in France working on the coverage of vaccines in France, and during our studies, there was an evidence that is the trust in healthcare professional is roughly 70% of the population. 70% of the population trusts the healthcare professional when they give an advice. So that is absolutely important. And when we are speaking about education, we should have in mind that the education of healthcare workers is absolutely important. But it is not a discrepancy with the education in general population. I remember some years ago I was in the U.S. Infectious Disease Congress, IDSA, and there was a report for the Massachusetts University about CME, the continuous medical education. And in this communication, they said that the most important way for the information and education of healthcare workers in the US was CNN. That is well, it is a fact. It is a fact. But
maybe an alarming fact, but fact.
Yeah. But it is a fact. But that means that the healthcare professional is a human. Is a human, and we have to have it in mind when we are implementing education for them.
Thanks, Dr. Stahl. A question here from a public health physician who's joined us today, who's been struggling with generating interest within their health unit on strengthening promotion around adult vaccination. Again, I think a lot of efforts post-pandemic and catch-up programs have been focused and continue to be focused on childhood and school vaccination programs. And there hasn't been as much interest in adult vaccination. When financial access isn't the barrier, how do we kind of continue to drive that narrative forward of the importance of adult vaccination and get that on the agenda? Perhaps we can come to you, Dr. Stahl, and then Emma, if you'd like to add some comments.
It is advocacy, because the only way to overcome this is to implement advocacy in France with the social security, that is the payer, or the government, because the social security is paying with the governmental money. And it could work. It could work. I have the recent example of the meningococcus B vaccine that was recommended but not funded in France. And we performed advocacy with the Pediatric Scientific Society, the Infectious Disease Society, and both we obtained that the vaccine was reimbursed. And now it is reimbursed. So it is possible. It is possible. But that means a lot of work and a lot of saliva.
Thanks, Dr. Stahl. Emma, somewhat kind of a related question, and I think it kind of speaks to the importance of kind of that conducive policy environment. I wonder if you could speak a little bit about some of the common criteria for NITAGs to make recommendations for vaccinations, and why shingles seems to be hitting that requirement in some instances, and in other countries seems to be slipping off the radar.
Yeah. So for most of the NITAGs that we looked at, there were kind of three main criteria, which were the burden of disease, the vaccine efficacy, and then a cost effectiveness evaluation. And shingles has traditionally been viewed as a disease that doesn't have a very severe burden. Which the more information that comes out about shingles, the more we know that this isn't the case, that there can be very severe complications associated with shingles. And really crucial to that is also that with an aging population, it's expected that we'll see a greater disease burden and a greater incidence as our global population continues to age. So while NITAGs historically have maybe not viewed shingles as meeting those three criteria, as we learn more and as vaccines become more readily available and as the population ages, it's expected that those criteria need to be reassessed and reevaluated by NITAGs, and maybe some of the recommendations may need to be strengthened to support the new information.
Thanks, Emma. I'm going to give Dr. Stahl the opportunity to respond, and then I'm going to come back to you both for closing remarks because we are quickly approaching the hour here. So Dr. Stahl, over to you.
Yeah, I think it is a matter. It was said before. It is a matter of awareness of the people, the politics, and the payers. They think that shingles, speaking about that, shingles is not important. It is not important, and it is not a massive outbreak. That's true. That's true, but they don't suffer from pain, when they say that. By the way, I think it is a matter of awareness. And a clear demonstration that it is an handicap.
Yeah.
Handicap. It is a real handicap. This pain is a handicap. Unfortunately, most frequently, the old patients are suffering from those terms. And it is not, if it was the prime minister sister, it won't be the same, So that's a matter of awareness.
And I think Emma's point, about data collection is also probably a significant thing that, if we don't have the data of what that looks like in coverage and the difference there, it's going to be difficult to kind of make those assessments. So I'm very conscious that we're rapidly approaching the hour. So I want to come to both Dr. Stahl and Emma for some just very brief kind of key takeaway messages. So Dr. Stahl, you first.
Be aware of this disease and vaccinate people. That's absolutely clear. As an infectious disease physician, it is my recommendation and it is my message.
Thanks so much, Dr. Stahl. Emma?
Yeah, I mean, that summed it up pretty well. Thank you, Dr. Stahl. But yeah, there's definitely an urgent need to recommend and fund these vaccines, and they are effective at improving the functional ability of older adults, especially. I would also just like to encourage people to view IFA's call to action on shingles immunization policy, which we can send out to the attendees of this webinar, and it's also available on IFA's website for anybody who's interested in learning more.
Fantastic. Well, thank you so much, Emma. And thank you so much, Dr. Stahl, for joining us today. We appreciate your time and expertise. And thank you, everyone, for joining us to celebrate Shingles Awareness Week. We hope you have a fabulous rest of your week, and I look forward to coming together in the future. Thank you so much.
Okay, thank you.
Bye.